about the impact of the recently passed healthcare legislation on us and our families. We have heard questions throughout the community and recognize the need for information from experts in the field. This evening was assembled by two groups, Chauncey Matters and the Hummingbirds, along with Laura DeFelice, our lifestyle director. For those of you not familiar with those groups, Chauncey Matters connects Del Webb to Westboro and Westboro to our Del Webb community. Two members of Chauncey Matters, Emily and Mirtha, are on the Chauncey Matters board and volunteer on the Council of Aging. Ed is also on the board of Westboro TV, which is taping tonight as a service to the greater Westboro community. Hummingbirds is an informal group that is looking for common, fact-based language to discuss issues. It is not affiliated with Del Webb. Some housekeeping information before we get to the presentations. Please take a minute right now and turn off your cell phones and your watches. Just double check, see if they're silent. As many of you may know, the restrooms are on either end of the hallway, so feel free to go ahead and use those facilities. We will not be stopping for questions until all presenters have finished. Index cards are on the tables. Please write your questions and hold them until all presentations are finished. At that time, I will ask you to hold the index cards up to be heard. I will read them to the presenters and give them the opportunity to answer. We will have a parking lot for planning purposes. We're hoping for a hard stop at 8:55 to conclude the presentations and questions. At 9 o'clock, we will have snacks and table conversations to reflect, discuss, and share. And I believe each table has a facilitator. Special thanks to Mike Klein for researching and reaching out to both John McDonough from Harvard School of Public Health and Cindy Phillips from the SHINE program to join our expert panel. We're also fortunate to have our representative at the State House, Kate Donaghue. Mike, please introduce Dr. McDonough.
Again, welcome everybody. I see some condo residents out here who do trivia with me occasionally, and I thought we'd get started with two tricky trivia questions. Feel free to loosen your lungs up and shout out an answer. I've already given you one hint. Which 1970s president pushed through, ultimately with bipartisan support, several of the most consequential health care and health insurance legislation of that decade, including the HMO Act of 1973, which legalized such organizations and provided federal support and requirements to encourage their growth? So who was it? 1973? Nixon. Very good. It was Richard Nixon. Now this one's a bit easier. You've all heard of the ACA, the official title for the law that critics named Obamacare. But where did the bones of the ACA come from? A certain governor's name was attached to a certain state's progressive health insurance program. Who was the governor?
Romney.
All right. And obviously from Massachusetts. Those trivia questions were meant to illustrate that sincere concern about the health of all Americans can result not in total agreement between parties, but in bipartisan legislation. Partisan, bad. Bipartisan, good. Turning to our first speaker. When I was getting my master's in social work at the University of Michigan, just down the street, a fellow from Waltham, Massachusetts, was obtaining a master's in public health. He moved on to Harvard's Kennedy School and then back to our alma mater for a doctorate. His public service accomplishments are noted in the flyer that was posted, and I want to emphasize that his specialty is the practice of public health. What medical science and healthcare delivery can do to improve the health of all Americans. John is here to help us remember and reflect on what has been going on with the healthcare and health insurance industry in our country since the administration of LBJ 60 years ago, when we were all in grammar school or junior high. Now in 2025, the U.S. has the 7th highest per capita income in the world and is by far first in the world for its number of billionaires per capita. Two related items appear to stand out. Americans' health hasn't been first-rate since the 1980s, and many of our 900 billionaires, individually or through their substantial control of mutual and institutional investment funds and the help of their legions of lobbyists, are heavily entrenched financially in for-profit healthcare and healthcare insurance companies. Understanding where we've arrived in terms of the public health of Americans and how we've ended up here can help all of us and our children and grandchildren become wiser consumers to better interact individually and as public citizens with our current system. Here's Public Health Professor John E. McDonough.
Hello, everybody. Can you hear me? Yes. Okay, great, thank you. Great to be here with you. Thank you so much. Thanks to Mike, thanks to Margot, thanks to all the folks who are part of this. It's exciting to be here with all of you. and pleasure to be here with Representative Donaghue and with Cynthia Phillips from the SHINE program, which is so essential in helping people make sense of this maddeningly crazy Medicare system that we have. And even more maddening and crazy is the whole US healthcare system. It's just amazing. I've been in this since 1985 in health policy when I got elected from Jamaica Plain to the Massachusetts House of Representatives and got appointed to what was then called the Joint Committee on Healthcare. And I just fell head over heels in love with health policy and have been engaged in it for more than 40 years now. It's just kind of an amazing thing. It changes every single day. There's not a day that goes by that I don't see something new. And sometimes, and so I spent 13 years in the House. I ultimately became the chair of the Healthcare Committee for some major events that happened into the 1990s. Sometimes I refer to myself as a politician in recovery. It's kind of a lifelong affliction that you kind of never get out of your system. It always hangs around there. So I'm here tonight to help you to think about and understand better Medicare, Medicaid, and the Affordable Care Act as they relate. I know that there's a lot of diversity here among this community, whether you're on Medicare, whether you're on Medicare and Medicaid, whether you're on ACA coverage, or something else. It's just very difficult to make sense of it. So I am not here to try to sell you anything. I'm not here to try to convince you of anything. I'm here to kind of help you make sense of things. Sometimes I think of myself in the role. Do y'all remember that movie from the 1990s called The Fugitive? Yeah. You know, Harrison Ford and Tommy Lee Jones. And you remember that scene in the tunnel? Yeah. You know what I'm talking about. So it was Harrison Ford had gotten Tommy Lee Jones' gun and was pointing it at him, and Tommy Lee Jones was looking up at him, and Harrison Ford says to Tommy Lee Jones, "I didn't kill my wife." And Tommy Lee looks up and says, "I don't care." So let me just say, and please take this the right way, however you feel about the healthcare system in the United States and your own political preferences or whatever, I don't care. However, if you tell me, I don't understand how this is the way it is and it makes absolutely no sense, can you explain to me how the heck this could have happened? Then I care. And that's what I'm here to do. I'm trying to help you make better sense of things and not here to try to sell you of any particular political program or whatever. So I have about 30 to 35 minutes to talk, and then I get pulled. And I could talk for about 30 hours on this. I mean, I do teach courses where collectively I talk that much about all of these things, but I've got about 30 minutes. So I have a lot of slides. They were mostly organized. Mike was good enough to send me about 7 or 8 questions that he thought would be most useful and informative to you. So I've organized my presentation kind of around that. I have a lot more in here that I won't get to unless in the discussion it's going to be valuable, and then I can pull it up in 2 seconds. And we'll make these slides available to anybody, and you can reach out to me after this if you have some burning questions or something that you'd like to know, okay? So let's get in, and so I'm start with Mike's questions. So he wanted me to present a little bit about the origins of health insurance. He was pegging it to the Great Society, which probably most of you remember. That was President Lyndon Johnson who launched the Great Society after he took over, after the assassination of John Kennedy in the 1960s. But health insurance in the United States started way before that. It goes back to the 1930s when it really started, and it started, believe it or not, in Texas, where hospitals and school systems decided they wanted to kind of figure out some way to allow their teachers to be able to prepay for hospital services if they ever needed. And that led then to the creation of what became Blue Cross plans for hospital care. And it was eventually joined by Blue Shield plans for physicians. But they were 2 separate organizations, and in the 60s and 70s they kind of merged together. So now mostly it's both, and there's very few that, and in the 1940s, what was added to that was commercial health insurance companies. For-profit health insurance companies owned by stockholders or whatever came to become a competing force to the Blue Cross plans. And an important thing happened, probably a lot of you know this, in World War II. There were wage and price controls over the whole economy during World War II, and employers were competing heavily for labor because most of the best labor was over in Europe or in the Pacific. And so they came up with this idea, well, we'll offer people health insurance if they work for us. And they got the Internal Revenue Service to rule that the money that employers pay for that should be non-taxable. And so that made it advantageous for the employer to do it, and it was a great idea to bring people in who wanted to work for, among other reasons, to get health insurance. That was just done through an IRS ruling in 1943. In 1954, just jumping ahead, President Eisenhower signed a law to encode that into federal law so that it had much more permanence and durability. And he said quite clearly what his rationale was doing. He wanted to see a health system develop which was organized around employer-based health insurance, getting coverage through your employer. And particularly he wanted to do that as an alternative to what his predecessor, Harry Truman, had tried to do in the late 1940s. Harry Truman took a plan that Franklin Delano Roosevelt's people had devised to create a national health insurance system. And Roosevelt thought of putting it into Social Security, thought it would be too controversial and might kill the whole thing, so he was persuaded to pull it out. And he hoped to bring it back later, and he died before he had that chance. And when Harry Truman came in as president, he took it up. He said, here's the program that we want to do to create a single payer kind of system for the United States. He ran into the jaws of the American Medical Association, the for-profit commercial health insurance industry, and folks who were very much involved in national politics and anti-communism in that area, who claimed that if you did Truman's plan, it would be communism in the United States. And so it went down to pretty heavy defeat. It never even got a vote on the floor of the House or the Senate. And that was probably a gigantic missed opportunity. But then Eisenhower came in, and Eisenhower said, I don't want to just, so Truman's plan is dead for now, but I want to make sure it doesn't come back. So let's create a system organized around what today is known as employer-sponsored insurance, or ESI. That's what we call it, and that is still the dominant way that most Americans get their health insurance today, is through their job. Chances are probably just about everybody here did it that way. So the next big thing after 1954 was 1965, when President Johnson, as part of the Great Society in 1965, signed the law that created Medicare and Medicaid. Importantly, if you're a lawyer or some of these things, the programs were embedded into the Social Security Act of 1935 because they thought that they would try to make people comfortable with this by saying, this is a building on, this is an expansion of what we created through Social Security. So literally, Medicare is Title 18 of the Social Security Act, and Medicaid is Title 19. And the Children's Health Insurance Program, which was created in 1997, that's Title 20 of it. So you can see sort of this logic that continues. And so that was arguably, we could have a great argument which was more important, the 1965 law creating Medicare and Medicaid or the 2010 Affordable Care Act. It's a pretty close thing. You've got great arguments on either side, so nobody wins, but you have an interesting conversation about it. But so that was of fundamental importance. So Medicare, when it was created just for senior citizens and no one else. In the early 70s, it was expanded so that folks who met the federal definition of disability could get into Medicare as well. So that's the under 65 Medicare population. It's a small part. It's only about 15 to 20% of the program, but it's very important for those people. So Medicare was that, and it has pretty much changed a lot over the years, and I'm going to describe some of those big changes. Medicaid was created in 1965 in the law that created Medicare, and it was really kind of a small afterthought. It was, it's an exaggeration to call it the caboose on the train. Hardly anyone paid a lot of attention to it, except for folks in states. It was initially a program that provided health insurance coverage for lower income mothers with dependent children who were on what was then called AFDC, Aid to Families with Dependent Children. And now it's called TANF, Temporary Assistance for Needy Families. But so that's all it was. And starting in the late 60s into the 70s, gradually, inch by inch, row by row, the Medicaid garden kept growing. And now it is much larger. Now it's about 70 million people who are in Medicaid. And it is the dominant program for lower income Americans. It's the way that most people below 138% of the federal poverty line, which is about $15,000 in household income for a single adult. Everybody below that benchmark is supposed to be able to get into Medicaid. We'll talk more about that as well. In 1994, Bill and Hillary Clinton made a big effort to do comprehensive health reform, redo the whole system from top to bottom. Hillary was the star of the show. Bill Clinton gave a dramatic address to a joint House of Congress. It looked like it was going great guns, and then it fell flat, and it collapsed, and nothing happened. But I worked in the Senate, the US Senate, on Senator Ted Kennedy's staff between 2008 and 2010 on the writing and passage of the Affordable Care Act. And we drew incredible volume of lessons from that failure. We would talk all the time about remember what happened then and paying attention and learning some lessons, and they were deeply informative for better and for worse. 2003, George W. Bush signed what was called the Medicare Modernization Act. That created the Part D outpatient drug program in Medicare that had never existed before. He also created the modern version of what is today known as Medicare Advantage, or Medicare Part C, which has, we'll talk a lot about that. And it also, by the way, legitimized and grew something called health savings accounts, which are health accounts you can create to pay for some of your bills. They are generally tied only to high deductible health insurance policies. So there's a lot of reasons. We'll talk about HSAs as well, a little bit, very important. And then 2010, President Obama signed the Affordable Care Act. And so each of these, I have a chart that I didn't put up here. I've got like the 10 major efforts for advancing health access in the United States, starting with Harry Truman. And I've got who controls the White House, who controls the House and the Senate, and so forth. And then I divide the bills into did they win or did they lose? And there were about 5 wins and about 3 losses. And then I write the question at the end, was this effort incremental or was it comprehensive? And the stark lesson that comes out from that, like it or not, hate it or not, whatever, is that every major effort at comprehensive reform failed. Harry Truman in the late 40s. Richard Nixon tried to do comprehensive reform in the early 70s, and it got lost in the Watergate mess. And Bill and Hillary in the early 90s tried to do it, 3 failures. And the incremental bills all passed. So you may not believe it, but Medicare and Medicaid is actually incremental. It's the biggest one we've had, maybe next to the ACA, but it's not comprehensive. When it was written, it was only for senior citizens and poor women with dependent children who were on AFDC at the time. And so it's grown to become that, but where it started, and ditto with the Affordable Care Act. Barack Obama was famous for saying, if you like the care you had, the coverage you have, you can keep it. It was deliberately designed, learning from the Clintons' failure, to say we're going to try to expand and improve the system for people who are not being well served by it now, and leave everybody else alone. That was a deliberate piece about it. Anyway, those are some important moments. Now, I'm not going to go through this chart, but just to make sure, in case everybody doesn't necessarily know, Medicare has 4 parts. And this is my chart. This is Medicare in a nutshell. The 4 parts are part A, B, C, and D. How many of you know A, B, C, and D? Everybody? Pretty much. Okay, pretty much. So part A is hospitals, and then other stuff on top of that. Part B is physician and outpatient care. Part C is Medicare Advantage. And Part D is outpatient prescription drugs. So oftentimes we call A and B traditional Medicare. And then C and D, new Medicare. For the most part, we just mostly talk about Medicare Advantage standing by itself. And you can see the dates and all of these things, but I just want to draw your attention to this line down at the bottom here. And understand a big difference between these programs that explains a lot about the political dynamics of Medicare. So generally speaking, with exceptions, but generally speaking, Democrats love Part A and Part B. And Republicans love Part C and Part D. And Republicans hate A and B, and Democrats generally hate C and D. Okay? And that, for the most part, explains the basics of understanding the politics of these programs. Democrats love A and B because it's government-provided health insurance without the interference of the big bad insurance industry. And they hate C and D as the playground of the big, gigantic insurance companies. Republicans love C and D because it's not government-provided health care, even though it is. Indirectly, through others. And it's the private sector working and innovating and changing and doing all kinds of stuff. And they hate A and B because it's government-provided health care. And so that's an important distinction to understand, because you'll see that play out in all of the debates that are going on right now, including the debates going on in the US Senate today, okay? And it's such a repeating pattern that it kind of gets a little wearying. By the way, if you just want to see, this is Medicare Advantage in terms of the share, the number in millions of people in Medicare Advantage, and the percent of Medicare that is Medicare Advantage. So you go back to 2011, and just under 12 million in Medicare enrollees were in Medicare Advantage Part C, about a quarter of the total enrollment. You go up to today, and it is in 2024, it's 33 million, and it's more than half. It was in 22 to 23, for the first time, Medicare Advantage became a majority of the enrollees. So this part of the program is really becoming dominant and growing, although it may be that this year will be the first year in more than 20 years when we're going to see the share of Medicare enrollees in Medicare Advantage go down. I don't know if we've got the numbers yet, do we? No, okay. But there's a lot of disruption in that market going on right now. You may have noticed, and so we'll see. But you go back, and you go back 10 years before this so Medicare Advantage didn't exist until 2003. It had predecessors. It had Medicare Plus Choice was the name right before that. That almost went belly up. And Congress, with the Bush administration, went in and did a rescue and created the modern Medicare Advantage or Part C program. And so it's been a big ride, and I would say that all of us are surprised to see how much it had grown, whether you're for it or against it. The growth has exceeded anybody's expectations. And we'll talk some more about that, okay? And then just a little bit, this is the numbers game, this is the money game. How Medicare gets paid, where the money comes from. And believe it or not, each part is a different story. Each part has, you could write a Dostoevsky novel about Medicare financing. But this is all of Medicare, so this is just on average. And so what you see is that about a third, 36%, comes from payroll taxes, right? You know, on your pay stub, you see the Medicare payroll tax. That's that, okay? These are general revenues. This is just these are appropriations in the federal budget process that go in. That's the biggest part. These are premiums that you pay, premiums and cost sharing and other kinds of things, and these are just a few cats and dogs. So this is the whole thing. But look at Part A, hospital insurance, because the Medicare payroll tax that you pay on your taxes, all of that money goes into Part A. So what you can see here is that the payroll tax comes to about 88%, 88 cents on the dollar, comes from that tax, and then a few other things. These are other benefits that gets taxed. And then B and D are mostly done through general revenues. Through the budget process every year, there's money appropriated. You may ask yourself, and it would be a good question, where is Part C? Did we forget about it? Well, Part C is a strange thing because it gets its money. You remember going to the beach in the 1950s and somebody's car was running out of gas and someone would have a hose and some daring person would stick one end of the hose into the gas tank of another car and then breathe in before the gasoline and then stick it in the other car that needed the gas, okay? So that's Medicare A and B versus Part C. Part C is the car getting the gasoline out of A and B. So everything that's done in a Medicare Advantage plan that is hospital related, it comes out of the Part A hose into Part C, and ditto physicians and so forth. So it's a strange process. And some people wonder, why is there a Part A and a Part B? And the answer is, when they were designing the law in the mid to early 1960s, they wanted people to look at this and see it as something familiar. And in those days, in the early 1960s, you didn't have comprehensive health insurance. You had hospital insurance through Blue Cross, you had physician insurance through Blue Shield, and so this was created to resemble that. Now, that no longer exists. Now there's only comprehensive. There's no more just hospital or just physician. But this lives on because there's a lot of legacy here, and it just kind of has a way of enduring, and it would be too complicated for what gain? What gain? Anyway. Orientations, philosophies of Republicans and Democrats, as evidenced by U.S. health system developments. So I've done some parsing and looking, and here's honestly what I conclude, and I hope nobody's reading disparagement into this one way or another. I think these are, for the most part, just factual statements. So Republicans believe it is important, it is a tenet that they hold dear, that the free and unregulated market is the best pathway forward, including health and medical care services. That's kind of fundamental, foundational. Cutting taxes and deregulating most of everything is the right way to go. So every major new Republican presidency where they have the trifecta, do you know what the trifecta is? Okay, when one party has the White House, the Senate, and the House. So when Republicans get the trifecta, they go and they do a big gigantic tax cut law. That was Reagan in the early 80s. That was Bush in the early 2000s. That was Trump in 2017, and now in 2025 again. So that is, I mean, cutting taxes and deregulating is quite important. Echoing Ronald Reagan, he said, government is not the solution, government is the problem. So you do things without government, and that is much better. And when government programs can't be eliminated, they should be privatized. If you can take it out and put the running of the program into private hands, that will be better. And the two biggest examples of that, by the way, are Medicare and Medicaid. Medicare Part C, Medicare Advantage, is privatized Medicare. And 80% of the non-disabled, non-elderly people who are in the Medicaid program are in Medicaid managed care plans. Most of them for-profit, commercial. So that is an example. So the best example we have of privatization is right in front of our eyes. Democrats, I would say generally, now Kate disagree with me, if you think, access to medical care is a human right and should be a legal right for everybody as well. It's not a legal right. It's a legal right for people who are included in it, but that doesn't include everybody. We still have, in the United States today, 25 to 30 million people without health insurance. So, but in terms of it being a human right, which is more kind of in the value sphere, that's it. Taxes are the price we pay for civilization. We don't have to love them, but we should appreciate why we have them. Free markets are good to a point, and every market, including healthcare, needs regulation to some extent. And there's an inevitable conflict in medical care between patient needs and corporate profits. That's my definition. Don't blame it on anybody else. If you don't like, if you think I screwed this up, then blame it on me. I'm holding this one. Here's an example, by the way, of polarization that is quite dramatic in terms of, so I remember when I was in the legislature in the 1980s, the mid-1980s, we didn't have a lot of Republicans, but we had a good number of them. And in the House and the Senate, we worked with them, we collaborated. Sometimes they were with us, sometimes they were against us. We would co-sponsor all kinds of bills and do all kinds of things. There's a lot of cross-fertilization. And in Congress, you see this in this top diagram of 1989 in the US Congress. The blue or the purple is the Democrats, the red is the Republicans, and you can see in the middle, there's a lot of cross-fertilization. So there were plenty of Democrats who were more conservative than some of the more moderate to liberal Republicans. There were actually moderate and liberal Republicans in those days. You jump forward to 2002, and you should be able to see a trend going on here. There's something that's happening. And you go up to 2013, and look at that on the bottom. So right now, there's nobody in the US Senate or the US House where there's a conservative Democrat who is, and can be matched by anybody on their side. The most liberal, there are no liberal Republicans left. There are moderate Republicans left in that branch, in the House and the Senate. But there's space between them where there was none before. And so that's another important dynamic as we look at this and understand this, okay? So, impact of major laws on Americans' health care. Why did programs evolve in many different directions, especially HMOs, health maintenance organizations? Probably the best articulation or personification of managed care. Managed care, HMOs, same thing, but there are other forms of managed care as well as HMOs. So, basic bottom line, absent some significant public regulation, medical costs go up, and they go up a lot, and they will go up by much more than the growth of our gross domestic product, or the size of the overall economy. And that creates a problem, because what you have then is medical care growing at a rate where it grabs everything on the table. It grabs money that you would like to spend on education, on public works, on environmental protection, on whatever it is that you might like to see government do in addition to health care. It gets crowded out and pushed to the side to pay for the bills in the medical care system. There was a saying in Bill Clinton's campaign in 1992 by the political consultant Jimmy Carvin. He said, he put on the board in the campaign headquarters, he said, "It's the economy, stupid." That was a message to the whole staff. So in 2002, a very famous health economist from Princeton by the name of Uwe Reinhardt, who passed away a few years ago, he came up with a healthcare variant of it, and he said, "It's the prices, stupid." And what he meant by that is, if you want to understand why healthcare is so expensive in the United States compared with every other advanced economy in the world, it's the prices. For any good or service you can name in medical care, we pay by far the most in the United States, by a lot. And it changes though, it changed. So when Medicare was created in 1965, there were no price controls in it. Hospitals were told to charge the government your usual, customary, and ordinary payments. Those were the three words. And that became just a gateway for incredible, massive hospital cost inflation. It wasn't until 1983, President Reagan, Bob Dole was the Senate Majority Leader, Tip O'Neill was the Speaker of the House, when the Social Security system and the Medicare Part A Trust Fund were going financially belly up, that the leaders got together and decided we have to regulate hospital prices. And so they put in place a system starting in 1984 called prospective payment, created something that probably a lot of you heard of, DRGs, diagnosis-related groups, all created in 84 and 85. And since that time, Medicare spending, Medicare grows because there were more and more of us going into the system. But on a per person basis, on a per capita basis, Medicare spending has been remarkably consistent and stable and steady, going on about 40 years now, and Medicaid as well. So in terms of where the cost problems and the affordability problems are most serious, it's not Medicaid, it's not Medicare, it's in private commercial insurance, particularly employer-sponsored insurance. That is the place that is going up. It used to be that employer plans would pay providers roughly parity to Medicare prices. Today, on average, Medicare prices charged to employers are 300 to 400% of what Medicare is spent on a per person basis. So it's a big deal. So that's the price point. So when they think about each side has preferred policy directions to go, and you think from the economist's point of view, demand side and supply side. So Republicans tend to like demand side measures. They think that the problem is that we have too many people consuming too many medical care services, people are too wasteful, and so we need to do things to make consumers much more cost conscious. So they do that with things like cost sharing. Cost sharing, unpacked, includes deductibles, co-pays, and co-insurance. You have that in Medicare. You all know you have it. You don't have it in Medicaid, but you have it in all of the private commercial and the ACA coverage as well. And also health savings accounts. Things to do to try to influence your behavior so you will not be so greedy and wasteful in your consumption of medical care services. Now, just to say, and the data proves this, we are not, in comparison with Western Europe and other advanced economies, we are not high spenders. We are not high rollers in terms of consumption. Our use of our physician visits are below what you will see in any other country. Our numbers of physicians and nurses, our numbers of hospital beds, our length of stay, whatever quality measure you want to use, for the most part, most of them suggest that we are not irresponsible consumers of medical care services as a population compared to Germany, France, Great Britain, Italy, Japan, you name it. Very different scene. Democrats tend to prefer what we call supply-side constraints, where they want to do models and regulations that will limit the growth of the sector. So the best example is Maryland, which since the early 70s has had a system of hospital rate setting that tightly caps and controls the growth of hospital spending in the state tied to the Medicare program and elsewhere. Those are the kinds of things. So that's a big difference. But in the 1970s, Democrats and Republicans both agreed that managed care and HMOs made a lot of sense. The notion was that you get rid of this division between the insurer and the provider, and you put them together into one organization, an HMO. I joined in 1976 the Harvard Community Health Plan out of Boston, which then became Harvard Pilgrim and all the rest. I remember when I joined, I would hear, the initials were HPHC. And some people said it meant horrible care for healthy people. But I didn't need much, I was young in those days. So I've been an HMO member for decades and decades and decades. Now what's happened is that when HMOs were started, you mentioned Richard Nixon and the HMO Act. HMOs existed before that, but the HMO Act was an attempt to try to build them up and expand them. Richard Nixon got very excited by HMOs. He thought this was going to be what would fix the system and control out of control healthcare prices. So he was all for it. And Ted Kennedy, who I later worked for when he was in the Senate, was also a big fan. He thought that HMOs could be the foundation for a new national healthcare system. And the HMO Act didn't do that well. By the end of the 70s, the growth was anemic. And so in the early 80s, when Reagan came in, he scrapped the HMO Act, and he said to all the HMO plans, we think you're great, but what you really got to do is you got to all go for profit. And you got to convert to either be bought by insurance companies or convert yourself to for-profit. And that actually was the gasoline that catapulted HMOs to grow enormously and very quickly, so that by the 1990s, they were dominant in the US healthcare system. And they became pretty muscular. Some of you may remember there was a scandal in the mid-90s around something called drive-through deliveries, where HMOs were telling new mothers you got to get out of the hospital in 48 hours or 72 hours. And that created a whole revolt all across the country. State legislators, including Massachusetts, we passed a bill to regulate or control drive-through deliveries. But there was a lot more. That was just the start of a big HMO backlash that went for the whole latter half of the 1990s. And at the end of the 90s, the employers told the HMOs, listen, we've got costs pretty well under control, we think, and all of our employees are very pissed off because of all of your little requirements and stuff, so back off. So the HMOs backed off, and the insurers backed off, and then into the first decade of this century, healthcare inflation reignited, and it was back again. And that's when we saw the big reintroduction and the big fast moving of cost sharing, of deductibles, co-payments, and co-insurance. and it's been growing enormously since then. So lots of things going on here, very complicated history, lots of lessons from all of it. Important to think about a little bit, and the question from Mike about income and wealth disparities, longer lives, costly technologies, for-profit entities in healthcare. So in the 1970s, there was a big, vigorous debate in the United States about, so we all agreed healthcare was a mess. Healthcare was an example of market failure. And so the question was, what are we going to do about it? And so the direction that Reagan and his folks and Republicans wanted was, the problem is that healthcare is not enough like a business. And we need to open it up and deregulate it and let it do whatever it wants. And if it messes up, then it'll get punished in the market and no problem. And Democrats believed in price regulation, price controls, and for the most part, it was Reagan's team won that debate. Very much involved and associated with an economist you probably heard of named Milton Friedman, Nobel Prize winner for economics, very important guy, part of a whole strand of American politico-economic reality starting in the 80s called neoliberalism. Liberalism not in the sense that you think of it as liberals today, but liberals in the spirit of Adam Smith from the 18th century, he was the father of the free market. And so that set of beliefs took hold, and that was a time when we saw, for the first time, a big, gigantic entry into the healthcare system of for-profit healthcare. Not just for-profit, because there's always been for-profit. Physicians have always been mostly for-profit. But what we saw was the entry into the healthcare system of major shareholder-owned corporations who had to regularly report to Wall Street on their financial returns and had to make decisions like United Healthcare does now in terms of leaving markets or going in and so forth. Friedman was actually he wrote a very famous op-ed in the New York Times in the early 1970s, September 1970. And he said in it, his message was the sole duty of the for-profit corporation, the sole duty of the for-profit corporation is return on equity to shareholders and nothing else. All this stuff about duty to consumers, all this stuff about obligations to communities and so forth, that's bunk, that's hippiedom, that's communism. You just go and you do it. That strand is what led to the series of events that created a phenomenon in the United States. It started in the 80s and 90s, but took off in healthcare in a big way in this century called private equity. Private equity, finance and investment, where it's all about you come in like Steward Healthcare, you buy up a system, you milk it for all it's worth, you take the land that the hospital existed on and the property, you sell it to a real estate investment trust, and you scoop up all that money, and within 5 to 7 years you've sold it to somebody else and you're out the door. The people who bought up Steward left 7 years later with about $800 million in their pockets to do it. So that's a big, and so that was a big period. It's also a period when we lost sight of traditional antitrust. We used to think of the United States in traditional antitrust, big is bad. When companies get too big, sometimes, it's because they've got really innovative stuff, but sometimes it's because they're buying up all their competitors and squelching them before they can grow. And we saw that take off in healthcare in a big way. So now we have our big mega provider in Greater Boston called Mass General Brigham, which is huge, which is trying to buy up things wherever they can. And you end up then with a lot of lack of competition and rising prices. And the economists who studied this very closely have concluded if there's one thing that explains why costs are so out of control in the United States, it has been the explosion of for-profit corporate consolidation over the past couple of decades or so. Anyway, I'm out of time, am I? Tell me what I'm doing. Tell me when I gotta shut up.
750? Yeah, you kind of are.
I will stop. There's a lot more, but you can see it. We'll send it around, and I'll be here for Q&A, and I'll be here after when you're doing your table talk if any of you want to talk to me as well. So this is just the appetizer, right?
Yes, it is. Okay, so Mike, if you would introduce Cindy Phillips, then we'll move on to the next.
Wow. Our next presenter, Cynthia Phillips, goes by Cindy, has been the statewide director of SHINE since 2009 and was involved with SHINE long before that. She's faced her share of challenges, and I'm afraid Cindy has some more challenges coming down the pike. She's going to discuss the current status of government-run Medicare Classic and the benefits offered to seniors through Medicare Advantage and Medigap policies, which are, whether from nonprofit or for-profit companies, private insurances, as John explained. First, a little background on her program. Some of what I'll share, she might have to, as a state official, refrain from discussing, but I'm going to lay it out there and see what she says. SHINE is our state version of a national program known as SHIP. Here in Mass, SHINE is a teeny tiny unit within the $800 million State Executive Office of Aging and Independence. It used to be called the Executive Office of Elder Affairs. Despite SHINE being teeny tiny, it reaches a lot of seniors and is very popular. Many in this very room, I know many of you have taken advantage of SHINE guidance through the Senior Center, yet SHINE finds itself in the crosshairs of budget cutting by the current federal administration. The state's Executive Office of Aging and Independence covers most public funding of actual health care for seniors, Medicare and Medicaid. But SHINE's money can only be drawn, if I understand correctly, from Massachusetts' share of what in FY25 was $55 million nationwide. That's for 50 states. And Massachusetts is 16th in population, so you can imagine, just do the math. This past April, a leaked HHS budget proposal by the current federal administration included a significant cut to SHIP funding. SHINE in Massachusetts is a SHIP-funded program. It just goes by a different name. The proposal that was leaked in April by the administration eliminated about $55 million in the annual funding for the program. So 55 million? 55 million? What's left is nothing. Though a smaller congressionally mandated $15 million was proposed, emphasis proposed, as a bipartisan amendment to keep SHIP running through the first quarter of the fiscal year, October through December. We are now in December. But that couldn't be acted upon until very recently at the end of the shutdown, when the continuing resolution was passed on November 10th. As far as I can make out, the continuing resolution will continue only through January 31st, 6 weeks from now, or 5 weeks. So it appears that right now SHINE can only rely on, and how soon the money would be available is unknown, about 90 days of funding at the FY25 level. Cindy, if she can share it, or our third panelist, I'll lay this on, Representative Donaghue, may have more information, but SHINE's FY26 federal funding beyond January 31st looks to me very complicated. I would say I'm worried whether it'll be there at all. If Shine is to survive, it may well be that its services will have to be even more dependent on volunteers. As most of you know, Shine counselors are volunteers who provide free, unbiased, individually focused assistance to residents at locations such as local senior centers. After you hear Cindy and what she's struggling with, I hope that some of you, with the education you're getting tonight, would be willing to consider signing up to be Shine volunteers.
I paid him to do that.
That's an advertisement. Take it away, Cindy.
Thank you, Mike, for all of your research. I will add that we somehow or other do have funding that lasts through June, and we receive additional funding from the Medicare Improvements for Patients and Providers Act to extend that funding. So, you know, we're okay. Plus, we have this fabulous legislative body that helps with earmarks, and that has helped us sustain and keep our 14 regional offices going. So, you know, we're hopeful. There has been changes in the staff that we look up to at the federal level. A lot of them are no longer there. The grant writers are no longer there. Some have been moved from the administration of community living to the new administration for children and families or whatever. So there's been a lot going on for sure. But we want to help people, and that's what we're here for. And, you know, knock on wood. Must be wood under there, right? So thank you. So John has talked about quite a few of the items that I plan to do, but I will speak through them pretty quickly. So the reason that Shine is different than, say, Shine in Florida, or High Cap in New Hampshire, or Choices in Connecticut is because, for some reason, when the SHIP programs were designed at the federal level, they let the states make up the names, which sounds good, but then we're like, well, how do people even know who we are, or what we are, or what to support us, if we sound like we're all different names, right? So we've tried to have some branding to be similar, etc., but I'm not sure that it's worked that well. Anyway, the idea was to provide unbiased, comprehensive health insurance information for people with Medicare, about to be on Medicare, with Medicare and other needs, you know, just to be there and to connect people to services in their states as well. As I mentioned, there are 14 regional offices. Needham is the closest office here. They're also a regional office. Well, there's a Westboro office, but Needham is a regional office. So we do keep in touch with them. There are approximately 700 Shine counselors, and we do train new counselors every year. We have a new learning management system, so we hope to make it easier for people to go through the training and, you know, focus on areas of need that maybe don't have coverage and counseling available. We actually have 90 bilingual counselors, and a lot of them at our agencies. So, you know, agencies, hospitals, community health clinics, aging service access points, housing, where people live, have also found it's just valuable to have this information. A lot of people come to us because they've helped their family member with a Shine counselor and say, yikes, I should know this. You know, I should know it for me, I should know it for my family member. And a lot of times that's how they come into the program. So again, you know, 57% are volunteers, and they work volunteer hours, and the rest are agency staff primarily. Languages and dialects we love because we want people to this information is so confusing. You know, I think I mentioned to Barbara earlier that when I first started in Shine back in Burlington, I had an attorney call me and say, I have 4 degrees and I cannot understand them. I've been doing this for years and it changes constantly, so it's not easy. All right, I think I mentioned already what we want to do. But in addition to Medicare, we find people that, you know, for some reason or whatever, they're lower income. In Massachusetts, we know how we struggle with money sometimes. And there are several programs that help people pay for Medicare. One is Mass Health for people who are lower income and can provide a lot of different services. Some just help pay for the Medicare premiums, like Extra Help or Medicare savings programs. So the counselors learn all of this in detail, and they learn how to either help people apply or at least screen them and say, gee, I know you're feeling a hardship now, but why don't you apply for this? Here's a one-page application, and that could really help them. There are a couple of programs we also help people learn about senior care options, which is very extensive. It combines Medicare and Mass Health, and the One Care for people under 65 combines Medicare and Mass Health. All right, you already learned about Medicare A through C and D. I do want to mention that we work a lot with Medigaps too, and I don't believe that was mentioned earlier. But when we educate people about Medicare and the options to fill Medicare's gaps, of which there are many, Medigaps always come up. But again, I think we've seen the fact that the Medicare Advantage plans have had zero premiums for a long time, and that tends to help drive their enrollment. Medigaps are more expensive, then you gotta buy a Part D plan so you don't get penalized. That costs money, so, it's kind of money. Okay, and again, some rules change in July because of the big beautiful bill, and that is to restrict people getting into Medicare so that, they have to have the 24 months, but also be permanent residents. 24 months of Social Security, under 65, be permanent residents, Cuban Haitian entrants, reside in one of the COFA communities, be a U.S. citizen, have paid payroll taxes for 40 quarters through themselves and their spouses. And we have been told that as of 2027, that people who have Medicare and do not comply with these immigration standards may lose Medicare, even though they've paid into it for years. So, that's in that bill. For people who need to sign up for Medicare, we don't know why you don't go to Medicare to sign up. You just don't, right? You go to Social Security, okay? Because they can check whether you've worked all those quarters. So that's the phone number, ssa.gov is how you contact them. We have special contacts when things fall through the cracks or when there's a big problem. We're lucky we have some connections at the federal level that we can ask about. We recommend people make an account with Social Security so you can keep track of your benefits and everything. Medicare costs money. We did talk about the hospital deductible. You could be at a hospital 3 times a year. If the benefit period has been used, then it could cost you almost $2,000 every time you're in, if you don't have something to help pay for that. Medicare premiums $202.90 per month. Annual deductible is $283, and so forth. To pay for a Medicare drug plan, it can be $8.40 a month or up to $238, but why anybody would pay that, I have no idea. But, and then again, if you work, and if you have worked and your income has been high, you might have extra premiums added to those Part B and D premiums. And also people who are struggling financially, they might say, well, okay, I enrolled in A, it's free for me, I worked all those years and all those quarters.
Excuse
but
me?
I don't want to sign up for B because I don't use it, I'm healthy. Well, guess what? If a certain time goes by, you could get a penalty on that you carry your whole lifetime. Same thing with D. People tell me they don't need medication.
You want to turn down?
Okay, but you may have a penalty the rest of your life.
Excuse me,
Sign up for it.
Could you hold the microphone up?
I'm very sorry. Is this better?
Yes.
Thank you.
I'll turn it up a little.
No, it's those mics.
Okay. There are a number of enrollment periods to get into Medicare or to add a Medicare drug plan or Advantage plan. I apologize. If you missed anything, you can talk to me afterwards. We'll have a one-on-one.
Yeah.
So the first opportunity to sign up for Medicare is around your 65th birthday, as some of you may know. Or 7 months around the birthday, you can defer it if you have coverage. Then there's a general open enrollment period every year between January 1st to the end of March, where if you didn't sign up for B, you signed up for A because it was free, but you missed the opportunity to sign up for B right away. So they do have that opportunity. There are opportunities to enroll in Medicare C, Medicare Advantage plans or drug plans, or B, again, with special events, like you moved out of the service area of the current plan you have, you retire, there's an emergency, a weather issue, that could be another reason to have a special enrollment. Medicare Advantage open enrollment, Medicare open enrollment for Part C and D just ended on the 7th of December. So that was an opportunity. And now Medicare Advantage open enrollment will start January 1st to the end of March. For people who didn't enroll or realized, ooh, I signed up for something before December 7th, and now I realize my primary care physician is not in that anymore, so I need to make a change. Okay, so again, there are a bunch of enrollment periods, and as shy counselors, when somebody comes to us with a problem, that's one of the first things we think about is, can you make a change? And we think, oh, well, if you have, a mass health related program, you can make a change. If you want to set up for prescription advantage, you might be able to make a change. So we're all about trying to help when there are issues that happen. While I have your attention, I just thought I'd mention, hardly anybody used the preventive benefits under Part B. Here they are. Lots of screening, flu shots, vaccines, nutrition therapy, mammograms, glaucoma tests. Use them because they're yours. You paid for them, you deserve to have them and to be on your side. All right, as was mentioned, there are different ways to fill gaps in Medicare. You saw those gaps, a lot of it was money, right? How much money it costs for hospital care. So, as was mentioned, original Medicare is Medicare A and B together. And you can add a drug plan, freestanding, or a Medigap plan, and/or a Medigap plan. The other option is the Medicare Advantage plans, and there's all kinds of those, which generally include a prescription drug plan. How do we do this? When we work with people to help them decide, I've had people come to see me recently who've said, I have no idea what to look for. I've gotten 45 pieces of mail. I don't know what's a good plan. We go right to the plan finder and type in the medication list, the preferred pharmacies, the zip codes. We can look up providers. Most of the time they're correct on the website. To try to at least help them narrow down what makes sense to them. We do recommend people set up a Medicare account as well, so they don't have to retype that list every single time they come to Medicare. You can check on your preventive benefits. You can see your office visits. It's a really good thing to have. And that's what the plan finder looks like. There's usually a nice gentleman and a woman on the front smiling and happy because Medicare is wonderful. And we go to find health and drug plans before we start our plan sections. Click on that, start typing in, and it's usually fairly easy. You can look up providers again, and you can chat with somebody. We plan to do a lot of training on that this year. We realized as everything went crazy during this open enrollment that a lot of people do not know how to use the plan finder. And that's something we really have to teach people to do. Because there's a lot of smart people, like yourselves, who are smart. You can all learn how to do that. So that's one thing we'll be doing more presentations on this year. I just wanted to mention that, a few years ago, there was an out-of-pocket payment for prescription drugs that you had to pay for up to $8,000. With the Inflation Reduction Act from the previous administration, we had an out-of-pocket threshold at $2,000, and in 2026 it's $2,100. So even though you might have really expensive medications, you go through the plan finder, you find a plan that covers them, you're not going to be paying what it looks like you're going to pay. Your maximum out-of-pocket will be $2,100 for the year, and that's a really big help. So what happened to Part B, D in Massachusetts? These are the drug plans. There were 6 companies that sold 11 plans, down from 14 plans offered in 2025. The least expensive plan, again, I had a friend say, listen, I don't take any medications, I don't want to buy a drug plan. Well, do you want a premium of expense the rest of your life, or do you want to pay $8.40? So that was kind of easy to talk with her about that. 2 of the plans have a $0 deductible, and a lot of them work with extra help. That particular program that helps people pay for their medications. There are no 5-star plans which allow you to make a change announced as of yet. And there is a $615 deductible, which sounds like a lot. But some of the drug plans don't require you to pay that if you're using a generic or preferred plan. Medicare Advantage. We have 10 carriers in Massachusetts that offer all kinds of plans, 43 plans just in Worcester County alone. How do you figure that out? Do you eat any mighty mower? There's a lot of people who are now used to the extra benefits target those. I've had counselors say that people will call me and say, which has the best flex cards? I want the card with the best groceries. I'm like, ugh. It's really not what we're trying to get here, but it makes a difference to some people. Another, you probably have been aware of this, but there were 3 health insurance plans that had 0 premium preferred provider organizations. In other words, an HMO, yes, but a wide provider network. 3 of them terminated this year. So for 2026, 80,000 people received letters that said they needed to change their plan because they would no longer be eligible. And they said, call Shine. They were like, what? Not us. Yes. Sometimes when plans go out of business or change, they can actually crosswalk the people over to another plan, but they couldn't do it this time because 0 premium to what? You're not going to crosswalk people to that. So people have had a special enrollment period to get a different plan. And it goes to the end of February, but there's a glitch in there. Like if you don't change your plan or pick a new plan by the end of December, you won't have a drug plan January 1st. And hopefully people read that. So anyway, that will still be open. A couple of the plans added hospitals like South Coast. Milford Hospital became associated with UMass, and I know that had a lot of people worried because they didn't know what was going to happen and what insurance companies were going to be involved. What happened to the PCPs? And a lot of movement this year. It's unbelievable. One of the plans that was discussed a little bit earlier, one of the programs, had 15,000 PCPs saying, forget it, I'm not working here anymore. And they left. And just think of all of those patients who are connected to those providers now really worried. What are they going to do? Some of the counties had fewer plans this year. Mass General Brigham, yep, they have a new Medicare Advantage plan, a new senior care options plan, and a new one care plan. So they're, really expanding in the market. A lot of the plans have preferred pharmacies, but we were fascinated to find that even the preferred pharmacies aren't necessarily the best prices. Sometimes they are, sometimes they aren't. So, it's a little bit of a toss-up. And just a reminder, if you or anybody you know find themselves in a situation, January, February, March, where you realize your provider is no longer your Medicare Advantage plan, or the one that you selected does not seem to be the right one for you, there is an opportunity to make a change during those 3 months. All right, and I just mentioned that there are Medigap choices too. That was one of the options, a drug plan plus a Medigap plan. There are 7 providers. And you can find these on the Medicare Plan Finder as well, but Massachusetts is different, as you know. We know we're very different. Our Medigap plans do not screen for whether you smoke or not. They do not say, oh, you're old, so you must pay more. And they have to be open continuously. So these are not age-rated, they're community-rated plans. And it's just kind of hard to access them on the Plan Finder, but they are there. We have Supplement 1 for people born before January 1st of 2020. 1A, which is exactly the same coverage, costs a little bit less, and you have to pay the Part B annual deductible of $270 or something like that. So it's not a big change. It is a savings if you choose the 1A. And then there's Core that pays for some of it, you know. Yeah, so anyway, again, the Medicaid in Massachusetts are a little different, like a couple of the other states. These are the plans that we screen for to help people pay for for Medicare. We also contact the Mass College of Pharmacy. You might have heard about it. They're not far from here. Right, in Worcester. They're our best friends, and 3 of them are Shine counselors, and you know, they're awesome. They give us information. We call them all the time. I talked with one today. Vicky, I just have this new expensive drug that this person has, and they don't want to leave their Medicare Advantage plan, but it's not covered. What can we do? Oh, let's look at the generics. Let's try this manufacturer discount plan. You know, there's another one through GoodRx, and Needy Meds has plans. So there's just a lot of options for people, and they're a really great resource for us. Just a couple words about the Health Connector. People who are eligible for Medicare cannot stay in the Health Connector if they turn 65 and have been in it. They really need to get a Medicare plan. However, if people have maybe been working but not worked those 40 quarters to have premium-free Medicare A, you can stay in the Connector. There's some really good rates in the Connector, and people really like that if they can do that. So, you know, those are options for them. But, you know, if they don't sign up, and they should have signed up for Medicare, they might have a later on penalty. The other thing that we reiterated today is that the Senate did not save those APTC tax credits for the under 100% population or the 400 to 500% population. So I'm sure we'll be hearing more about that. We work among this older advocates committee of legal assistants throughout the state who put together materials for people that say, okay, they're off Health Connector, they're off this, they're what's left. And a lot of times that's, you know, a very basic mass health plan or the health safety net. You know, so there are alternatives. There are a lot of lawyers thinking about this and how they can help people stay on health insurance or at least get something that helps cover them. So, you know, nobody should ever think that they are totally deserted around here. You know, we want to help, we'll find resources, we'll do what we can to help people. And here's some of the places to go for help. Medicare advocacy is specifically for Medicare-related issues. We have a lot of other resources as well. And that's the Shine program. That's the end of my story.
Thank you, Cindy. That was great. That's a lot of good information. Now I'm asking Mike Hart to come up and introduce Kate Donaghue for us. Here it is.
Hi. The third speaker this evening is Kate Donaghue, who is Chauncey Lake's representative at the State House in Boston. Hello? Yeah. To continue, our third speaker is Kate Donaghue, who is who is Chauncey Lake's representative at the State House in Boston. Kate and I have known one another for quite a few years. She represents 5 of Westborough's 6 wards, including our own, but also represents parts of Northborough, Southborough, and Framingham. She is vice chair of the House Committee on Federal Funding, Policy, and Accountability, and has been a vigorous advocate for general health care funding, with a particular interest in supporting mental health initiatives. But she also shares with us an experience that's become all too familiar, caring for an older parent who increasingly relies on a constantly changing healthcare system. I hope we're going to hear from her on that. So it's my pleasure to introduce our voice in the State House, Kate Donaghue.
Thank you.
So, as Mike mentioned, Mike and I have known each other for a long time. Let me just get this out of the way. Mike and I have known each other for a long time, and I've lived here in Westboro for 51 years. I remember when this was the state hospital, and I'm watching the building of this, and if I understand correctly, you're going to have 700 units at build out. Just for my information, how many of you here are full-time Massachusetts residents, or how many have permanent residency? Most here are Massachusetts residents. And how many live in another state where this is your winter residence? A few. Well, that's good. Well, I mean, either way it's good, but I just was wondering how many of you could benefit from the Massachusetts-based programs, Shine and everything. So, as Mike said, I'm a regular person. I saw the program flyer that said I'm an expert. Well, I'll tell you what, I'm not an expert. I'm not like these two. But I am a consumer. And as a legislator, I learn a little bit about a lot. Sometimes people ask me, do I enjoy being a legislator? And I tell people, I learn something new every day. And on a good day, I get to help someone. And it's a very rewarding part of my job. So, like you, I have my own unique experiences with healthcare. We all have our own stories. When my late husband was a career employee of the Commonwealth, so he did not have his 40 quarters in. And like some of you who might be retired from the Commonwealth or municipality, when you reach age 65, they tell you if you're eligible for Medicare, you have to go on Medicare. So at age 65, he goes over to Social Security, not Medicare, to see what's up. And they tell him, you're not eligible, you're not eligible. So he goes on, he's able to stay on the state-funded insurance. Then I turned 65. I had my 40 quarters in, so that he knew I had to go on, Medicare. Well, it turns out, although no one ever told him that when I was eligible, he was eligible. So they wanted to charge us like 130% penalty for the rest of our lives. Even though he has this letter that says, you are not eligible. They never asked him, do you have a spouse? The whole thing is very confusing and caused us a huge amount of stress. It's not something you read about because most, not everybody, but most people do have their 40 quarters in. So that was my first experience with the vagaries of Medicare and dealing with our bureaucracy and all the misinformation. Then the next big change in my life, very major change, was when I got elected to public office. And I just figured I'd keep my life simple. I'd stay on Medicare, and I was getting my supplemental through my late husband's GIC. Only, shortly before I was about to be sworn in, they said, oh, no, you cannot stay on the GIC because that's you're getting a retiree benefit, and you're going to be a full-time employee. So I tried to figure it out and ask around, and everybody's giving me different advice, but there was one common theme in the advice I was getting, and that was, talk to Shine. So I'm talking to older legislators that might be in a similar position, and they're like, yeah, I talk to Shine. How else are you going to figure this all out? So that was one of the experiences that I had. I did want to talk a little bit about, as Michael mentioned, my mom will be 97 tomorrow. And a couple of months ago, she was hospitalized with pneumonia, and they told us that she needs 24-hour care. Well, that was what a doctor who saw her for a couple of days at her worst set. But it was kind of a wake-up call for us. And that's one of the things that I've seen, so suddenly 2 months ago, we were plunged into trying to get this 24-hour care in place. Like many people, my mom wants to stay in her own home, and we're committed to helping her age in place, as they say. I'm very fortunate. I'm one of 7 living children, and there are 7 living children-in-law. There are 14 different opinions, but between the 14 of us, we're doing the best we can to keep Mom at home. So I wanted to talk a little bit about that journey. We have, interestingly, and kind of unexpectedly to me, shifted more to using cameras. I said that to somebody and she thought I said we were switching to using cannabis. We are not caring for my mom, but giving her cannabis. But what we did find, and this is more generally related to healthcare, was that, like so many people, my mom wants her privacy, wants her independence. She doesn't want caregivers in the house. She's like, yeah, it's fine to have people, as long as one of my children are children-in-law. And even with 14 of us, there's a limit to what we can actually do. But we found that with the cameras, we are able to give Mom her dignity and her privacy, and give us the ability to be in our own homes. About a month ago now, my mom fell, and I was watching her on the cameras when she fell. She seemed okay, but she can't get up. She's scooting around as fast as she can on her butt, just trying to find a way to pull herself up. And I was still a little new at the cameras, but within a few minutes, we were talking to her. Mom, someone will be there. At the 7-minute mark, my mom actually gets herself up. At the 9-minute mark, one of my brothers and his wife arrive, and at the 10-minute mark, another brother arrives. So we saw that as kind of proof of concept, that we can make this work. And that's the good news. The bad news is that we know that these things will just get more serious and more serious. But I wanted to talk about one of the programs that we did end up finding a lot of help from. And even as a legislator, and this is a state-funded program, I wasn't as familiar with it as you might have thought I should be, as somebody who works for the Commonwealth. But some of the programs that we looked at were the home care program, I'll be talking about that, offered by the Commonwealth. The GUIDE program, which is offered through Medicare, I'll talk a little bit about that, as well as benefits for veterans' widows. While there are resources available, I found that the income limits for some of these healthcare programs are incredibly low and really should be updated. But the program that has been the most beneficial to us, and I'd encourage people to become familiar with it, is the Commonwealth's Healthcare Services Program. The program includes the Frail Elder Waiver and is available to Massachusetts residents. Its goal is to help adults age in place, with services available to people aged 60 plus, people with disabilities, and people with early onset Alzheimer's or related dementia. I have a few copies of a handout I made up somewhere. So I have the flyers. Here they are. I can give out like one to each table and you can take pictures of it. But it shows a lot of the different services that it may provide, not always. I didn't know about all of them. I was interested to learn that you can get electronic comfort pets. I didn't even know they existed. But as I was preparing for this, I learned about electronic comfort pets. And as I said, I can give one of these out to each table, take a picture of it. And it has my contact information as well as I just wanted to mention, John mentioned it earlier, but the Mass Health Connector updates. There's a new online portal as for this constantly changing situation. But the home care program services, the services are available based on assessed need and cost for these. The cost for the services are based on the income. So what I learned was that to access these services, you need to go through the Aging Services Access Point, your ASAP. There are 24 of these regional groups across the state, and each municipality is served by a different ASAP. And the one that services Westboro is Springwell. A lot of them are referred to as elder services. So for example, it's Elder Services of Worcester is that. But Springwell would be the one you would go through here. So if you have a loved one in a different community, you can find a list on the website. I put the URL on the flyer for people who need that. And what they do, among other things, is they'll assess the person and do an income evaluation. When they assessed my mom recently, they said, on a scale, what is your overall assessment of your quality of life? Excellent, good, fair, or poor? Superior, my mom says. She's a delight to be around, but I'm looking forward to her 97th birthday. And the 24-hour care, well, it can be challenging to your schedule. It has made us more intentional about spending time with my mom, and now I'm getting emotional. And it's also made me more intentional about spending time with my brothers and sisters. And although there are challenges, it's in some ways a blessing to be visiting my mom. And I took her here to Westboro. I signed up for, we have to sign up for shifts. I signed up for a shift before I realized it was the day of the Westboro Senior Fair. So I took Mom out from Westboro and we went to the Senior Fair together. We each bought necklaces for $2. Go to the Senior Fair if you haven't, every year. So it turned out that my mother is eligible for, she was eligible before, but it's sometimes a challenge getting seniors to accept these services, as I touched upon. So it turns out that my mom's eligible for 4 hours of covered care per week. And so now we're getting her 2 hours, two-hour shifts of personal care. And based on my mom's income, it's a very modest price for, the way it works is they assess you for what services you're eligible for and how many hours, and you pay one price for whatever you're eligible for, and that's income-based. And in addition to the 4 hours of in-home personal care that she's getting, we switched from an electronic monitoring service that we were paying $80 a month for, and that's included in our monthly fee as well. So it's a very helpful program, and it is, it's run by the Commonwealth. And interestingly, I'm going to touch a little bit on that, what the services that my office offers. But when we were trying to get my mom signed up, we were having trouble getting a call back. And it happens, but in my particular case, I was able to get a call back by calling my mom's rep and saying, hey, I'm having trouble getting a call back. And with a call from her rep, we were able to get a call back. And when I talk about the services that my office offers, we're here to help cut through red tape. We seldom are in a position to make a difference in how a case is decided, but we can typically make sure we have eyes on your case. We can typically make sure that you get a call back. So I wanted to make that point. One of the other programs that we're utilizing is one of the other programs that we're utilizing is the GUIDE program. And that's a Medicare program, and it stands for Guiding and Improved Dementia Experience. The model is voluntary nationwide testing the impact. So the goal is to provide comprehensive services and support for people with dementia and their caregivers. So right now it's in a what they call a model program, which started on July 1st of 2024, and it will run 8 years. So essentially, the problem that this program is trying to address is that people with dementia often experience fragmented care that leads to poor health outcomes. And they typically need comprehensive caregiver support. And it is designed for people who are being cared for, like in our situation, by loved ones at home. So family caregivers who are often, like, I keep telling my mother that most of her kids are now senior citizens. It's just the truth. So family caregivers are often, they're dealing with Medicare themselves, and they bear significant mental, physical, emotional, and financial burdens. And so the GUIDE program is intended to help with that support. Based on my family's experience, it hasn't been super helpful, but the GUIDE program, the model advances coordinated dementia care to support people with dementia and their caregivers by providing evidence-based services, including 24/7 access to a support line, caregiver training, and education. And the one that's actually been most helpful to us is that they offer funding for respite services of up to $2,400 annually. So it's not a lot of money, but if you're trying to do 24-hour care, that can get very expensive very quickly, and every little bit of help adds up. So that's still an ongoing program, so they're going to be studying the outcomes. I think that that kind of program would be more helpful for people without the network that my family has. But just interestingly, of the 7 living children, my sister is actually quite handicapped herself. She can no longer drive. She's a quadriplegic. But she has Wednesdays. Someone takes my mom to visit my sister on Wednesdays, and she stays there for several hours. My sister might not be able to help my mom if she falls, but she can call 911, she can manage an emergency, and they get to spend some time together. So of the other 6 living children, 5 of us work full-time, and that's the kind of situation a lot of people are in. But my sister, bless her heart, spent ever since she retired, she spent her time preparing for this. She's been learning about this, going to support groups, learning about what programs are available, learning about what to expect and resources. So the kind of services that the GUIDE would provide weren't as helpful to our family. It might have been more helpful if we didn't have if my mom was living in a different part of the country than we were living in. And of the 14 of us, 13 of us live less than an hour from mom. And how many people have that kind of support network? I'm just very grateful that I have that. And I didn't think I was going to be able to take up all the 20 minutes. A couple of nights ago, I was at the Willows for a speech contest for high school students. And they had to talk a minimum of 5 minutes or they lost points. And they couldn't go over 7 minutes or they lost points. As I was preparing for this, I was saying to myself, if I don't use the whole 20 minutes, nobody's going to deduct points. So I wanted to conclude with a little bit about the constituent services that my office offers. And I am a full-time legislator. I have 1 staffer. So as John can attest to, there can be a lot that we need to handle in the time that we're working. So we do try to get back to everybody within 24 hours, but that's not always possible, but we do strive for that. So the constituent services that we offer include helping with agencies and state issues, like the RMV. Unemployment especially is a significant part of what we do for constituent services. Again, we can't impact the outcomes, but we can make sure typically that there are eyes on your case. Particularly with unemployment, it's wonderful to be able to help people to get a call back, but I have to express a little frustration that it takes a call to a legislator to get your situation resolved. And we can help connect people with the Health Connector and Medicaid. There are a lot of issues that are actually federal, but we can help connect with your congressman, everybody here who's a registered voter in Massachusetts, Congressman McGovern is your congressman, and we can help connect with other federal cases like Medicare, passports, and the VA. We can help bridge the gap with regional and local service providers. We've worked with UMass Medical, National Grid, and Eversource. And one of the things that we've been able to help with is fielding and communicating concerns and ideas regarding state projects. Right now, this district is home to the biggest Department of Transportation project in the state. That's the 495-90 interchange. And a lot of the staging is not far from here, right on Route 9 near 495. And so I've worked with them to mitigate the dust and noise with the people in the neighborhood behind that, the little strip mall. And I also worked with them at the request of the businesses. The big dirt piles were impacting the business, people eating outside, and people seeing their place. So you may have noticed that the dirt piles moved from the northern side of Route 9 to the southern side, where they have less of an impact on the business. So if you've got anything like that, and one of the fun things that we do is we can host groups and give tours at the State House. So the Southborough Senior Center did a tour. And if anybody, I don't know if you have those kind of activities here, but if you're looking to go for a tour of the State House, we'd love to have you. The library at the State House is beautiful. When I was, as John could tell you, I don't know how different things were when he was there, but when you're in your first term, you have very tiny little offices, so we would always meet in the library. I was privileged to become a vice chair in my second term, and I tell people my new office has a door that closes, windows, and a wall that goes from the floor to the ceiling. I had none of those things in my first term. So it's a pleasure to be here. And I just want to say, I know this is an over 55 community, and this is my third career. My first career actually was in hospitals, and I was interested in John talking about HMOs. When I was an undergraduate, I studied medical technology, and as part of my studies, I studied HMOs. Because I was working already in the healthcare field, my professor said, why don't you do your semester project on this? So I studied HMOs, and at the time, I don't believe we had any HMOs in Massachusetts, but my employer was Fallon Clinic, and they had hired their first employee as they were exploring HMOs. And through my political work, I've done a lot of things, and I remember in the early days of HMOs talking with an obscure lieutenant governor of Vermont who was a physician, and we were working on some environmental stuff together, and we spent like 8 hours hiking this property that we were looking to acquire, talking about everything, including HMOs. That obscure lieutenant governor went on to become governor and then run for president. How many of you remember Howard Dean? And what Howard told me as we hiked through the Bolton Mountain area that day was that medical ethics are high enough now that he didn't think we'd see a detriment to healthcare, but he expected that would change. And towards John's point, he says, yeah, HMOs are great for healthy people, and back point. So I did want to, I can turn it over to Margot, but I wanted to mention, just show you these. I'll pass them out when you're done.
That would be great.
take a picture of them, or if we run out, Mike told me he'd get printouts for anyone who needs them. So thank you very much. You've been a great audience.